A brief idea about how the cellular components and the enzyme activity lie. This is important to understand because there are two major regions in which these enzymes reside. They are either in the mitochondria or in the endoplasmic reticulum, and you need to have an effective shuttle mechanism to shuttle these steroid metabolites. So first of all, cholesterol is pushed into the mitochondria using star. I'll talk a bit about the steroidogenic acute reactionary protein, and there are multiple enzymes which are there to act upon. You have got the 11A1 and you have got the donor, which is the adenotoxin reductase. After that, you have got the steroid is shifted back to the endoplasmic reticulum where you have the 3 beta hydroxysteroidehydrogenase and 21 hydroxylase activity, which is there along with 17 hydroxylase. So these major activities are happening at the level of endoplasmic reticulum, where your major electron donor is POR. Now, if you remember this, what it means is that POR is regulating your three major activities, predominantly 21, 17, partially 3 beta, and there is one more which is aromatase. So if you have a problem in the P450 oxidoreductase system, you will have mild salt wasting because of 21 hydroxylase deficiency. You may have DSD in both XX and XY individuals because of aromatase deficiency as well as 17 hydroxylase deficiency respectively. Now from here, it is again pushed in where you have the production of cortisol, which is then pumped out of the system. So there is a intricate pathway which regulates. The central part, of course, is the cholesterol. If you have got no cholesterol, you will not have any steroid which is being synthesized from that regards. So 11A1, B2 and B1 using the ADR pathway are predominantly in the mitochondria, while 17, 21 and 3 beta are predominantly in the endoplasmic reticulum, which becomes important. And of course, the aldosterone synthase will result in aldosterone production, and DHEAS will predominantly come from the endoplasmic reticulum system. Now, the whole process starts from cholesterol, and we already discussed that cholesterol is very, very essential. Now, where does the cholesterol come from? So, cholesterol can be produced within the cell or it can be transferred into the cell. So, what is the relative importance, Dr. Vibha, in terms of the cellular production versus the transfer?
So, for the transport, we require some enzyme for the transport. If there is deficiency, so the cellular part becomes important. So that's why.
So it's predominantly the intracellular production is there, but transfer is very, very important. And transfer can happen using the lipoproteins, which are important. So you can either have a LDL or the HDL pathway, which will work on that. So this cholesterol is transferred into the mitochondria where it is converted into steroids. As we discussed earlier, this can be produced directly in the cell using the HMG-CoA process. Now we know that HMG-CoA inhibitors will I use a lot in terms of statin. Do they interfere with steroid production?
No, they do not.
Why?
Because there are other mechanisms by which cholesterol can be entered into a cell actually.
And they would decrease how much do they decrease cholesterol by typically?
Depend on the how much dose we are giving.
No, how much percentage? Roughly 20 milligrams of rosuvastatin will decrease by
10 to 20%.
Maximum 20-30%. So if you have somebody who has a familial hypercholesterolemia whose cholesterol is 500, you expect it to come down to maybe 300 or 200, but not normal. So they will not make it zero. And the amount of cholesterol required for steroidogenesis is minimal. So that's why this is not going to make any difference in terms of that. Now you can have cholesterol via the LDL pathway, and this cholesterol is produced from 7-DHC in the cholesterol pathway using the DHC7 enzyme. And we'll talk about all these activities where the problems can happen. Now LDL, and we talk about these lipids much more in detail later on, using the LDL receptor and the LDL receptor associated protein, it will then be transferred into the cell. That will be a source, and this cholesterol cannot stay in the cell. So what will you do? If you are in charge of the adrenal cells and you have to keep this cholesterol inside, now cholesterol is lipophilic, it will go out. How will you capture it?
We'll bind it to some stable compound.
So you will stabilize it. You will make a bank deposit sort of a thing. So cholesterol is then converted into cholesterol sulfate, which is the bank deposit. Using the enzyme, you have got again a bidirectional enzyme. You have got the esterase and the lipase. Now, one way is esterase, the other way is lipase. There is no big difference. So LIPA is the one which is there. So what will happen if you have a problem of cholesterol esterase?
Cholesterol esterase, there is no sulfation.
Okay, then so that will of course have a problem in terms of storage. You will have a lot of cholesterol which is accumulating. If you have a lipase problem, what will happen?
Then there will be much quantity will be there of cholesterol sulfate, but cholesterol will be not available for steroid.
So it will behave like glycogen storage disease. Remember the day we talked about that if you do not have any glycogen synthase, you will not have any glycogen. So you will have deficiency there because this cholesterol will be lost. You won't have any cholesterol here. While if you have a problem in lipase, the cholesterol is going inside, but you cannot take out. So you have accumulation of that. The most severe form of that is what is known as Woolman's disease. So in which you will have got large adrenals, calcific adrenals, the cholesterol accumulating in the bone marrow. So a lot of other problems will happen. So this process of cholesterol production, which happens here using DHC7, which basically if it's defective, you have got what is known as a Smith-Lemeli-Opitz syndrome. So which organs will be affected if you have a cholesterol synthesis problem? If you have too little cholesterol. Yes. And where else do you think fat is important? So liver, which organ requires fat? Vibha?
The ovary require fat like.
So that's a steroid. That's a very late thing. So in the sense like which other organ system requires. So one we talk about endocrine system. You can say estrogen, progesterone, everything is produced via the cholesterol. But that is brain. So brain requires a lot of fat. So if you don't have a cholesterol, you will have neurological implications which will happen. That's why it's very, very important. So that becomes very important from the perspective. Now, there is also a side pathway which is not very commonly used but may also be relevant in certain scenarios using the HDL pathway. Now, this HDL goes in via the enzyme CLA1, which is in fact regulated by two opposite scenario, yin and yang phenomena you can call it. One is NRA5F1, which increases this activity, and DAX1 or NROB1, which decreases this activity. So if you have too little of NRA51 or SF1, or you have got too much of DAX1 or NROB1, you will not get this cholesterol coming in. So this will result in a steroidogenic pathway problem. So within this diagram, we have talked about problems of Smith-Lemeli-Opitz syndrome, Woolman syndrome, and the milder form of Woolman syndrome, actually, which is an autosomal recessive form, is just presenting to you like a fatty liver sort of a scenario. And here we have talked about problems of DAX1, which is basically adrenal hypoplasia congenita, and NRA5F1. In both of these conditions, you may have abnormalities in the test gonadal development, in the androgen production, in the cortisol production, and adrenal development as well from that perspective. Now, cholesterol, once it has reached the cell, whether it is endogenous production, LDL or HDL, needs to be pushed into the cell. Under normal process, it will happen. I've talked about cholesterol is basically what? Cholesterol is a lipid, so it can easily cross it, but then the speed will be less. At what level do you control or regulate the steroid hormones? At the level of production or at the level of release?
Production.
Why? Because it's easy to produce, quick as compared to a insulin, PTH. You need much bigger molecules. They have to be broken down. Steroids, immediately you can produce. Second, can you store a steroid? You cannot, because it will escape. Same problem. So cholesterol, cortisol, you can't store it. So you will regulate it at the time of production. So what it means is that you need to increase the rate of production hugely during time of requirement. So this normal process of cholesterol transfer will not be good enough, and therefore there is a special process known as steroidogenic acute reactionary protein which pushes this cholesterol. Now, which hormones increase the activity of star?
LH,
Yes, but most important is
ACTH,
ACTH, then LH, then what else? HCG, of course. Huh?
angiotensin.
Yes. So whichever is increasing the production of the steroids will increase the steroidogenic acute reaction. It's the same. Star is the same for everybody. So yes, so now the cholesterol is coming into the system much faster, and therefore your production rate will go up. There is also some role of NRAF1 which will suppress it. So again, it's working from that perspective. Now, if you have a star problem, what is going to happen in that scenario?
The cholesterol will not go inside the mitochondria.
It will go
Steroid.
at a lower rate. So it goes down to around 15%, 10 to 15%. So if you're producing 100 cholesterol was going in every minute, I'm giving an example, it becomes 15. What does it mean? The rate of steroidogenesis goes down. But that decrease in steroidogenesis, is it significant enough to cause crisis? Suppose you have having 100% activity, now it becomes 15%. No effect. Because if you talk about CAH, 21 hydroxy as an example, activity more than 5%, no problem. 1 to 5% you may have some problem, and less than 1% you will have crisis. So this first hit is not going to make a problem. So why do they develop adrenal insufficiency?
Cholesterol accumulates inside the cell and damages.
Yes. So now with time, you have less cortisol. ACTH is trying to push it up. So now you have got more cholesterol coming into the system. And this is the second hit which is going to damage that. So this will then be dependent upon, the manifestation will depend upon how much these cells are active. So where all is this star process acting? We already discussed about that. In the adrenal cortex, in the testis, and in the ovaries. Grossly 3 organs. So if I ask you which of these are superactive, active, inactive during the fetal phase. So most active.
Adrenals during the
Adrenals, okay, but the fetal adrenal is more active. The so-called adult adrenal is less active. Testis, testis are hugely active. Adrenals are active. Ovaries are
yes,
inactive. First estrogen is produced at what time?
during puberty.
No. First antral follicle is produced at what gestation? Term. So before term, the ovaries are not producing any steroids. So what does it mean in terms of their effect of star defects?
Star defect, there is a usually patient who will not get any effect until it start producing the follicles.
Yes.
Until like
So ovaries are unscathed. Testis,
testis will be affected, especially the Leydig cells will be affected more.
will the Sertoli cells be affected also?
It will be affected less than the Leydig cells
Why will they be affected?
because main testosterone production is basis on the Leydig cell.
So it should not be affected because these are different things. That's a peptide. So there the star is not going to make a big difference. So theoretically, they should not have that much of a effect in terms of the Sertoli cells. So testis, Leydig cells are gone. Adrenal?
Adrenal will be affected, mainly the fetal zone, which is
Yes. So adult zone?
adult. There is in fetal adrenal, there is definitive zone and transitional zone.
Yeah.
Adult zones are affected, but definitive and transitional zone will be affected, but it will take
So
time.
at birth, it will not be that much affected. After birth, once the activity becomes more, it will be affected. So adrenal insufficiency, if we compare CH due to adrenal hypoplasia completely gone, congenital adrenal hyperplasia, hyperplasia, and star defect. Timing of presentation.
Uh,
21 hydroxylase, DAX, NROB1, and third is your star. Who will present first? Who will present second? Who will present third?
the X1 will be present earlier
Why?
because all the zones are gone there. And
So?
it will take time.
So 21 hydroxylase, you're not producing any mineralocorticoid. So that is a trick which will present earlier, Dr. Vibha. 21 or DAX?
It's a 20 hydroxylase, then that's done.
Okay, I'll put it the different one. You are in the right track. Why do we advise adrenalectomy in CA? Some people used to say that you can go ahead with a medical adrenalectomy, you discuss everything about that and complete adrenalectomy. Because the adrenals are not doing any good. They are doing harm. So one people say, okay, androgens are being produced more. Other thing to remember is that the whole steroid pathway is blocked. So lot of natriuretic substances are also being produced. So it's not just that all of them will increase your mineralocorticoid activity like DOC. So in 21 hydroxylase deficiency, there are other substances which are actually antagonizing the aldosterone action. So they are worsening salt wasting. So in other words, salt wasting will be the earliest in 21 hydroxylase deficiency. That's one is a neutral phenomena. So it will, there's nothing. So there's nothing promoting it. It will present around 4 weeks, 6 weeks, something like that. Star, of course, will present much later because once you use it, then only the cells will keep on dying. So this is something important to remember from that perspective.